So David Kleiman here with the EMS Operations Division, and today we're going to do a clinical update, but I'd like to introduce you to our medical director if you have not met him. This is Dr. Eric Nix.
Hey, good morning. How are you guys?
Doc, thank you so much. First off, outstanding medical director, one of the best ones we've had here in Cobb Fire. I've known you for years, and for a little bit of background on Doc here, he was actually a street paramedic. He actually was a flight paramedic, and then he crossed over to make it even better for those of us in the field by becoming an actual medical director for an outside agency. So thank you, Doc.
Thank you. That was very kind. I think Nick Adams must have paid you off for that. So.
No, it's those years of working with my wife and helping us out at the college.
Some of the things that we were wanting to cover today are double sequential defibrillation, our Atrovent shortage. We're going to briefly talk about Remodulin and Flolan, which are being used in the community for pulmonary hypertension, fire transport, and then go over some new medications that we're going to be adding to the field. Double sequential defibrillation is an interesting concept. It's something that's been done for a few years. Not a lot of EMS providers are doing it. There was a recent article that was published in the New England Journal of Medicine in November of last year that basically looked at 400 patients that got enrolled. They got randomized to either getting something called double sequential defibrillation, which we'll go over how to do that here in a minute, versus a vector change defibrillation, and then compare that with how we do that as a standard defibrillation. And it was pretty much even who got split into what. And they measured survival to hospital discharge with neurologically intact being the #1 goal. And if you look at the standard group, about 13% of people were able to be successfully resuscitated and survive to discharge. The vector change group, about 21% survived to discharge. And if you look at the double sequential group, 30%. So it's a drastic change, about 2.5 times or 2.2 times relative risk for having a successful defibrillation and surviving to hospital discharge neurologically intact, which is what we're really looking for. So based on this study, as well as some other case series and some other studies, Cobb Fire is changing its protocol. For ventricular tachycardia and ventricular fibrillation patients, we're going to do 3 defibrillation attempts with a standard defibrillator and an AED count. So if you get there and the BLS crew has defibrillated twice with an AED, then you would do 1 standard defibrillation before moving on to our next defibrillation. Always do quality CPR because that's the basis for everything that we do. If after 3 attempts the patient remains in ventricular fibrillation, any further defibrillation should either be used with 2 defibrillators, so dual sequential, or vector change defibrillation. It does require a second defibrillator to do the dual sequential. Puckett's medical director has given the go-ahead. They're on board with this. I'm still waiting to hear from Metro's medical director to get a formal protocol for Metro to adopt this as well. Wellstar is also on board with this. We're changing the way that we're doing it in both the ED and the ICUs for cardiac arrest that we have in hospital.
You're saying that at Metro, you're waiting for them to respond. So if those crews who are north or in Metro's territory keep our rescues coming, and Cobb Fire can do the BLS AED and our rescues to do the dual sequential as we're getting ready to turn the patient over to Metro, you're good with that?
Correct. You can use a standard AED, let it charge analyze a rhythm for VFib, shock with that one, and shock with a regular AED or a regular defibrillator at the same time.
So we can at least go through the double sequential, like the doc wants us to, as we're getting ready to turn that patient over. We're all here to save a patient's life, to do what's the best outcome for these patients. Thank you, Doc.
So standard defibrillation, you have your pads here and here. You can move on.
So what I've noticed here is that when we were looking through American Heart, if you read the meats and potatoes of American Heart, it actually says that your left anterior pad should be at your 5th and 6th intercostal space mid-axillary. The manufacturers over the years have been putting these pictures. And so this is a great picture that you're showing where we normally put the pads, and most people get that mid-clavicular in the left anterior spot, not really where American Heart wants. And so, like on the next slide, I was trying to show you earlier, that if we put our pads where we normally do, in the right shoulder area, and that left side, according to the picture, it's mid-clavicular, it's not where American Heart says it should be, which is that 5th, 6th, mid-axillary, that when you do it under an MRI, you're actually missing that whole posterior and that left ventricle.
So I think this is why changing the pads for a vector change improves survivability, because it gets the whole entire myocardium and you defibrillate the whole entire thing, which is also why a dual sequential will also work as well. I think the increased energy from dual sequential as well as the increase or decreases in the vector changes will help with it.
So for those BLS crews who are waiting for a rescue to get there or an ambulance provider to get there, just think, if you're shocking your patient, and we all know high stress environment, patients in cardiac arrest, you just put your pads on, and let's say you're getting to that second shot, that BLS provider, while waiting for ALS, can immediately think, I can start going towards a vector change if they get to that third shock.
Correct.
So on the vector change defibrillation, the best way we should be putting our pads on, and correct me if I'm wrong, Doc, but when you're looking at the pads, they actually will say, give you a little drawing of, hey, this goes on the right anterior chest wall, or it'll actually say front, and the other one will actually say left lateral or back. So the preferred way, because this is biphasic, we should be putting the one that says front down about here, and on the back, left side, right underneath the scapula, right by the end of the scapula, and that does the best biphasic. And remember, guys, on biphasic, instead of going electricity from my left hand to my right hand, by you being biphasic, the pads will actually read the impedance, all that fat, that muscle, that bone density, and what it does is it gives a longer shock from front to back. Front to back, a longer defibrillation. So this would actually be the preferred way. So for the BLS crews, or even those ALS providers who are first on scene, try your best to look at your pads, see the one that says front, go front, and do the other one in back.
Yeah, the anterior posterior will definitely have more successful defibrillations.
And we all saw the picture a minute ago how if you're just keeping them on the anterior side, you're missing a whole section of that heart, that posterior and part of the left ventricle. So let's say the BLS crew gets theirs first. You guys do your anterior pad and your posterior pad. Best way to defibrillate your patient. Let's say you're already on your second defibrillation. Rescue gets there on scene. Rescue, you see they put anterior, posterior. You go ahead and put your pads in your normal placement. Remember, try your best to get this pad in that 5th, 6th mid-axillary line. And now we are set up, Doc, for that dual sequential or a vector change.
And dual sequential is the preferred method if you can do that, just because of the higher survivability associated with it.
That's right, the 2.1 outcome. So the rescue, if you get there and you've already seen that they have their pad placement, put yours on there. That patient's in VFib or VTAC for that third shock, go ahead and hit them with a dual sequential.
So in order to do the dual sequential, you'll basically connect 2 defibrillators or an AED and a standalone defibrillator. Connect the pads as you see on the diagram that we went over. You'll synchronize the defibrillation, so charge it to 200 joules, or with an AED, let it automatically charge. When the AED indicates a shock is advised, push that shock button and push the shock button of the regular monitor at the same time. The article looked at doing it within 1 second of each other. I don't think you're going to cause any damage to the defibrillator by doing it at the exact moment. And the 2 times that I've done it in the past, I've done it at the exact moment without any consequences. And both patients were resuscitated.
So I know at the cath lab at Cartersville, what they do in there is they get 2 separate people. They look at each other and they go, "We're going to defib. I'm charged. You charge. Push it on 3. 1, 2, 3." Simplest way. Or if you have both monitors in front of you, you actually are the better person.
Right.
But that's something to think about. If you're low on manpower, best thing to do is you control both buttons, or do a small countdown and make sure you guys know what you're going on. And remember, if you're using this with an AED and one of our monitors, you've got to wait for the AED to do the 14 seconds. So it's going to analyze and then it's going to charge. Once that AED is ready to defibrillate, you're going off of them because they have to wait that 14 seconds.
I will say it's a very eerie feeling to hear 2 defibrillators charging up simultaneously like that.
And make sure you clear, because this is 200 joules. Remember, biphasic's going to read that impedance threshold, that fat, that bone, muscle densities. So even though it's 200, it might be 260. You don't know. So just make sure everybody's clear.
Other than the change in defibrillation, continue to follow standard ACLS. Remember high-quality compressions because they're key to survival as well. We recently found out that we have an Atrovent shortage, which probably is to be expected because we had an albuterol shortage for a while. Ware has been very good in sourcing albuterol for us. Now we have an Atrovent shortage. Just continue your standard protocol and don't use Atrovent unless it's somebody that's really in distress. We're trying to preserve some of our supply so that way we don't run out. Always remember, if you have somebody that's critical, Epi-IM works very phenomenally well. So I would highly encourage you to consider Epi for somebody in status asthmaticus.
Most severe. Severe CHFers, COPDers.
Probably should be limited to asthmatics because
Okay.
albuterol will help more for the CHF wheezing than Atrovent will for that.
All right. And so on those severe ones, let's say we do finally run out. Guys, don't forget mag sulfate.
Correct.
A lot of people forget about mag. Fantastic drug for respiratory distresses.
It is, and you don't need to administer it over 2 hours, which is what the standard protocol is for MAG. I have to argue with nurses all the time for that. So we recently received notification that one of the patients in the community had a Remodulin infusion going for pulmonary hypertension. I forgot what station it was that they sent notice to. There's actually a lot of people in the community that are taking Remodulin right now. It's used to treat pulmonary arterial hypertension. Flolan is one of the drugs that's used. It has a very short half-life of about 3 to 4 minutes. Remodulin has a longer half-life, around 4 hours. Flolan is something that if it's cut off, it can literally, if there's some disruption in the supply, like the IV tubing gets kinked or something, it literally can cause a cardiac arrest within a few minutes with that. They usually try to give these through a central venous line or a PICC line or some sort of port. So that way, because the continuous infusion through a peripheral line will cause thrombophlebitis. And it is a continuous infusion and they are dependent on it in order to live. So if they call you and they're having sudden shortness of breath, that should be the first thing that you investigate to make sure that the Flolan or the Remodulin is properly infusing. Both of these relax blood vessels. If they're given in really high doses or if you rapidly infuse it or bolus it, it can cause systemic hypotension and can cause a sudden drop in their blood pressure from that. They do inhibit platelet aggregation, so they are prone to bleeding, like whenever you start IVs and stuff like that.
So, but these patients that we're going to see or potentially show up, these are going to be those serious sick patients that sometimes are like in the hospital beds and stuff, or are they sometimes functioning members walking around and they just at night put in their...
So they function 24/7 with this pump in place. You know, you may be at Walmart and respond to a call there if something happens and it comes out of the port, or if they have their pump malfunctions. So they do get around in the community.
So just remember, when you're doing your overall investigation, start looking for those. I mean, we've all seen what the little ports look like, but now start thinking about, remember the life vest people, we used to always look for the double, gun slinging things here for the batteries, you know what I'm saying? Because they always had all the extra batteries on them. So now start thinking about this, sudden onset of difficulty in breathing, the person looks like they're severely sick. Do your overall investigation. As you're listening to breath sounds, oh, hey, I see a port. Start thinking about this.
And most of these people will have family members or them themselves will tell you that they're on this. If it's not infusing properly, you're going to see that they're pale, they're diaphoretic, they're going to have extreme shortness of breath, rather. Sometimes they can be confused, much like I feel right now. So it is important to inspect the pump and the tubing and to restart it immediately if you see that. And a lot of these, they will have a paper or a card with them that'll have their cardiologist's cell phone number or their pulmonologist's cell phone number. I encourage you to either call them or call me or one of the other medical directors so that we can give you some advice on what to do. If the pump or not the pump, but if the port is not functioning or if the central venous line becomes occluded or the PICC line, you can give this through an IV infusion. IO really is not going to work as well but you can start an IV, and preferably it should be a large IV, somewhere in the antecubital fossa or even an EJ, because it will allow better circulation for it and better absorption.
So if their pump completely fails, or that port is completely occluded, and we said, all right, we got to go down this road. Now the question comes in, what's the drip rate? Am I just looking for one drop every 3 seconds, one every 10 seconds? Because you're talking a small subset of the population, and now we are high stress, high anxiety.
And I think that's where it's going to be important that you make contact with the cardiologist, because each one is going to be individually tailored for their flow rate.
Yeah, so just get out that calculator and then tell them, and they'll be able to help you walk through a medication dose.
Fire transport, this seems to be less of an issue here lately because we had better availability. I will give the EDs credit for having better wall times, so we have more transport units available. Some of the EMS staffing shortages also seem to be getting better under control. But if EMS is unable to provide an ETA, if they tell you there's no ambulance available, if they tell you that it's more than 30 minutes before they can respond to you, and if the patient is critical, then you're authorized to transport them in a fire vehicle. It does require notification to command staff. Try to use a transport-capable rescue once we get those in service, because it's just better for patient restraint and also to provide treatment en route. The patient must be properly restrained. And if you're holding the wall whenever you get to the ER, as Nick Adams said, you're chosen the wrong patient to transport.
Well, so that's the key right there, guys. If you're holding the wall, you have dropped the ball here. So the question comes up, and the two big things that I've heard people when I talk about this is, if somebody says, okay, we make the decision, we have got to transport, we're not going to where they want us to go, St. Joseph's, Piedmont. We, because this is time sensitive, this is a critical issue, we should be going to Kennestone.
The most appropriate closest facility.
Most appropriate
in
closest.
some cases it may be Cobb if it's a burn patient, it's STEMI. If it's a stroke or trauma, probably Kennestone is probably the better destination.
And I bring up the elephant in the room, pediatrics. We decide, man, we got to transport this critical pediatric patient.
Probably should go to the closest facility.
And then just take the mom with us or parent or something?
Correct.
Okay.
And then they can arrange for transfer if necessary.
Perfect.
If it's that critical and there's no ground units available, CHOA ground can come, or they can send the helicopter from CHOA to pick them up.
Perfect.
And speaking of helicopters, this is one area that I know I've preached no helicopters in Cobb County, but pediatric patients, or if you're sitting on scene for a prolonged period of time and the patient's critical, that's definitely one way that you can get the patient to the ER.
And these TCRs, when we get them, it is the preferred method, like Dr. Nick said, better, your patient secured better working environment, and it's got our supplies. If you guys are going to transport in the back of a rescue or an engine, just remember, preload with the potential equipment you need as you're going down the road.
Right. So some of the new medications, I think a lot of excitement in the field about these. They've been a long time in the works. I'm going to briefly talk about etomidate and rocuronium before you get your, hopes up. No paramedic is going to be administering a paralytic, and we'll go over that. We're going to talk about Toradol, Cardizem, and then phenylephrine, as well as droperidol, which is one of my favorites. It's kind of supplanted Zofran as a new favorite. So rocuronium, we're going to start RSI with the MedOps team. Georgia regulations don't allow a paramedic to administer a paralytic, so only a registered nurse can administer this in the field, or a physician that's present on scene. So rocuronium can only be given by a registered nurse, and I cannot overemphasize that, because if a paramedic pushes a paralytic, we have to report it to the state, unfortunately. Even if the nurse is in direct sight of the paramedic administering it, the paramedic still cannot administer it. It has to be pushed by the nurse. There's nothing in the regulations that say that once the nurse administers it, that the paramedic cannot intubate the patient, so I'm perfectly fine with that. I do highly encourage you, if you're going to do RSI, you probably always should use a video laryngoscope, so that way you can get first pass success with it. So rocuronium can only be administered by people who have been specifically credentialed for that, and that right now it's only going to be registered nurses. Hopefully we'll get this rolled out by the end of the year.
I hope so. I know MedOps is excited about it. So, but just to reiterate what the doc said, when I flew in the helicopter, and same with you, the nurse was the one that always pushed it, and I was already up there. I had all my airway stuff laid out. I had all the laryngoscopes. I had my big bougie fan, and I had everything else ready. So as soon as I saw the patients paralyzed, I intubated. So
Yeah.
I'm assuming you did the same thing when you were flying.
Correct.
What about etomidate, doc?
So etomidate, right now we're not going to do drug-assisted intubation without a paralytic. It will be considered in the future, but etomidate can be administered by a paramedic.
And etomidate is a fantastic drug. Correct me if I'm wrong, doesn't etomidate also lower some of the ICP in those instances?
It does. It
So
does.
fantastic. You got a TBI patient, we decide, we've got to paralyze the patient. Man, etomidate lowers that ICP. And remember, sometimes when you RSI patients, you can increase a little bit of the ICP when you do the laryngoscope. So
Right.
it's a fantastic drug. And you guys will have further coming out about this, MedOps, for the actual dosages and stuff.
Yeah, there's a specific plan that we're developing for this, including a cadaver lab. So it's not something that we're just giving them a paralytic and telling them, have at it. There's going to be a lot of training involved for this.
There is, and he's explained a lot to us. This is something that the state takes very, very seriously. Dr. Nix takes very seriously, and you're setting us up for success, and we appreciate you for that.
So Toradol, I'm very excited to see added here. It's very highly effective alternative to fentanyl. Don't use it for patients at risk of bleeding. So if you have a major trauma, a stroke patient, or obviously a rule out AAA, then don't do it. Granted that a lot of kidney stones present the same way a AAA does, but if somebody's not hypotensive and they're having unilateral flank pain, more than likely it's probably a kidney stone and not a AAA. I found through the ER that it's great for gallbladders, it's great for musculoskeletal back pain, muscle sprains, things like that. If you have somebody, it's great for migraines too, but if you have somebody that says, this is the worst headache of my life, it was a sudden onset, like they call it the classic thunderclap onset, then those are people that are at risk for subarachnoid hemorrhage. You probably shouldn't give Toradol for them because if they are hemorrhaging, there is a slight increase in bleeding risk associated with it. Our protocol is going to say 15 milligrams for adults, IV or IO. If you give it IM, it should be double the dose, 30 milligrams. It's not really approved for pediatric use. We may revisit that a little bit in the future. You can repeat it once if no relief in 15 minutes if they're under the age of 65. And the max dose is 30 milligrams IV and 60 milligrams IM. And I know this is kind of contrary to what you might read in Hippocrates or a lot of texts and stuff. And the reason why we've set that is because there's some studies that have came out that looked at dosing and nephrotoxicity, so how much it damaged the kidney. And looking at this, 10 milligrams is just as effective as 30 milligrams in pain relief, but it has less nephrotoxic effect, so it doesn't harm the kidney as much. It's really hard because it comes 15 milligrams per milliliter. Unless you want to use an insulin syringe to draw up 10 milligrams, and so we just have set 15 milligrams as the standard protocol dose for it.
I'm all about KISS. Keep it simple in a high-stress environment. So the thunderclap, let's go back to this a minute, because I just had a patient recently who actually had a block shunt, had a headache, and then I was trying to see, do I have an increasing intracranial pressure? And I ended up not, because I like to think of thunderclap as that sharp stabbing driving through their heads. And that's how I take thunderclap. Is that a good way of doing it?
Some patients do present like that, but it's actually a rapidly intensive headache that is present within about 5 minutes.
Oh,
so if somebody has an onset, at most headaches, if you think about headaches that you might have had in the past, you get the headache and it may not get worse for a whole hour. Like it may just gradually keep building up. You can kind of feel it coming on. These people usually, it's a sudden onset. Within about 5 minutes, they get peak intensity. And some of the studies actually say peak intensity within an hour, but always it's within 5 minutes.
Got you.
So who really can't get Toradol? Cannot. People with kidney disease. So if you have somebody on dialysis, they really shouldn't be getting it. Anybody that tells you they have any degree of kidney failure shouldn't get Toradol. And the reason being is because it lingers around, it's renally excreted, and it does increase your bleeding risk associated with it. So if you have somebody also that has an active bleed, a GI bleed, a subarachnoid, like we mentioned, or a major trauma patient, then they shouldn't get it as well. That doesn't mean that somebody with an ankle fracture can't get it, because they can. Usually fentanyl is still front line for people that have suspected fractures, but if the fentanyl's not working, you can go with that certainly before you go with ketamine.
Gotcha. Well, what happens if we have bilateral ankle fracture, bilateral tib?
It's still okay.
Okay.
And then those allergic to NSAIDs, including aspirin, really shouldn't get it. And then be cautious with people with a history of asthma, because people with asthma sometimes have a higher rate of Toradol allergies associated with it.
Oh, really? Okay.
The only true allergic reaction I've ever seen with Toradol was in an asthmatic.
Really?
Yeah. So cardizem we're putting in the field because of prolonged scene times. We're going to be using it for atrial fibrillation and atrial flutter under a standing order. It's obviously not for ventricular tachycardia, because that'll make it worse. And you really shouldn't use it for SVT in the field either. If you do go down that route for using it for SVT, it will require an online medical control order, so you'd have to talk with the physician. But it's pretty rare to need cardizem for SVT. That's almost always a cardiologist that's ordering that for it. A bolus does not always mean that you need to follow it up with an infusion. A lot of patients respond to a bolus. So a single bolus or a double bolus will actually get your heart rate under control to where it needs to be. If you read the text, a lot of times it'll tell you 0.25 milligrams per kilogram for the first dose and 0.35 milligrams per kilogram for the second dose. But pretty much if you ask any ER doc, most of us are 10 to 15 milligrams. It's the KISS philosophy again.
Yes, sir.
And most of it, we just judge it, kind of guesstimate a weight, and then judge it based on that. So, you know, you start getting up, if you do the 0.25 milligrams per kilogram, you start getting into 25 milligram boluses and things, and a lot of times you see patients' blood pressure drop significantly. They get in the 80s or sometimes the 70s, and so a lot of us from experience just use 10 to 15 milligrams as the initial bolus.
And I know when I've pushed it in the past, when I was on the helicopter and stuff, when he says this last part about pushing slowly, it's like you said, your patients typically are 25 milligrams, and man, that blood pressure is plummeting about the minute and a half mark, and you're like, holy smokes.
Yeah.
So I like that KISS principle, 10 to 15.
And definitely, like David said, push it very slowly, because you're going to have a rapid drop in blood pressure if you bolus it.
This is pulling out the phone or the watch, and I'm telling you guys, do it slowly over 2 minutes. So let's say we get that massive hypotension. We know we're going to pull off and stop the cardizem. But should we start looking at, now I start trying to bolus my patient up fluids and stuff, or are we talking about, do I need to start chasing, like, hey, now I need to push calcium because I'm doing a vicious cycle? What do you recommend?
I wouldn't push calcium, because then that it's going to kind of negate some of the effects of cardizem, and then you're going to have the rate control not present. Most of them respond to IV fluids.
Okay.
It's very rare that you need pressors or anything for it. Most of it will respond to like a 500 milliliter bolus.
Perfect.
And a lot of it's temporary, because the hypotension will last a lot shorter than what that rate control will.
Perfect. So just remember, I'd listen to, because these patients we're pushing them on, you know, that AFib, A-flutter, you know, this RVR, make sure you get a good 12 lead and confirm, because like Doc said, you don't want to be doing this in SVT and God forbid VTAC. But just once we confirm, I'd listen to breath sounds, and that way, hey, I'm not going to fluid overload the 500, maybe 250 instead.
Right. If you give cardizem for VT, you're going to have a bad day. Patient definitely will have a bad day.
And then you'll have a Dr. Nix visit.
Speaking of pressors, we're going to be adding phenylephrine or neosynephrine. This should come in a syringe filled with about a milligram of it. It comes 100 micrograms per milliliter. It's a 10 milliliter syringe. You can use it for anything that's causing the patient to be hypotensive. It's not the preferred method for hypovolemic shock. Obviously, blood is, but it will temporarily raise their blood pressure, and it lasts for about 3 to 5 minutes.
Oh, good.
And the usual dose is about 100 to 200 micrograms, and you can give it every 1 to 2 minutes with it. We are going to be putting it in the RSI protocol as well for patients that are hypotensive or borderline, like if their blood pressure is 100, to go ahead and give them 100 micrograms of phenylephrine, so that way it'll raise the blood pressure and kind of counteract the effects of etomidate and rocuronium on their blood pressure.
Well, I could see the rest of the field post-arrest.
Right.
You know, because you have a post-arrest, I don't want to be doing way amount of fluid overload, because we're ventilating these patients and everything else. We don't know why they went into cardiac arrest. So this might be a good bridge for the rest of the field to be using to get this patient in the hospital with a stable blood pressure.
Phenoephrine's a great drug. I really love it.
I used to do the old push-dose epi, so I'm glad to see we have a better tool in the toolbox.
Droperidol is making a comeback. I touched on this a long time ago when I talked about ketamine.
Oh, yes, sir.
Many years ago. It's a dopamine antagonist. It also interferes with GABA, norepinephrine, and serotonin reuptake. To get into some of the biochemistry of it, it's really it kind of makes patients indifferent sometimes. It's kind of a unique thing. It's an antipsychotic as well, so it'll sometimes make patients, particularly like cannabinoid hyperemesis syndrome. You get people that are smoking marijuana, they're vomiting uncontrollably, and it really helps with their pain, their nausea, and just gives them this kind of indifferent feeling toward everything, and it really does control their symptoms a lot. I've had great success with it with migraines, with
really?
gastroparesis. We are going to require that you do a 12 lead EKG in the field because you really shouldn't give it to somebody that has a QT prolongation. So if their QTC is greater than 440, it really shouldn't be given with it, and you are going to have to continuously monitor the patient. So once you give it, they're going to be on the cardiac monitor until they get to the ER.
So just remember, when we all went through the Zoll training on these patients, this is the perfect one since you've already got them on the monitor. Do that snapshot before you left to transfer the patient to Metro or Puckett, because we have a snapshot showing that we did everything appropriate to the protocol by keeping them on the monitor the whole time as we turned the patient over. This is a fantastic drug, dog, if not for vomiting, especially people who've had any type of post-surgeries and stuff within a couple days or a week or so, and they're still vomiting. Fantastic drug for that,
Right.
is it not?
Yeah, we used to call vitamin D, Dilaudid was vitamin D, but I think droperidol is the new vitamin D now. If you're giving it for nausea or vomiting, it's 0.625 milligrams IV or IO. You can also give it IM. I didn't put it in the slide, but IM works just as well. If it's for cannabinoid hyperemesis, somebody with cyclical vomiting syndrome, gastroparesis, then you can double the dose to 1.25 milligrams. And if it's for the antipsychotic effect, which we don't have it in protocol yet, but it's 1.25 to 2.5 milligrams. And you can go up to 5 milligrams, and there's actually been some case reports up to 20 milligrams. But
Wow.
I really wouldn't, when you do that, you're really going to start prolonging a QT, and it can definitely get you into some bad waters with that.
And when he says indifferent, the ones that I've seen when it's been pushed in the ER, it's not like when we ketamine somebody and they're a sack of potato that we're trying to move around. These people are very suggestible to, hey, we need to walk over here, and they sort of, hey, I don't care, let's go that way.
Yeah,
I mean, that's what he means by indifferent. So they're a lot easier to control, unless you guys want a sack of potato and to carry around.
The whole K-hole
Yeah.
situation.
So if you have any further questions or you need additional training, contact the EMS Operations Division.